this video, we are going to review acute kidney injury, AKI. AKI refers to situations where, for various reasons, the kidneys cannot produce urine adequately when they should. There are many possible causes and some people memorize them with NCLEX. But when I discuss AKI with residents, it's often clear that they cannot apply those memorized lists correctly in real clinical practice. So today, I'd like to walk through AKI the same way I teach my own trainees, combining memorized knowledge with a solid understanding of pathophysiology, so you can use this knowledge both in exams and in real patient care. According to KDIGO, AKI is diagnosed when any of following are present: an increase in creatinine level of 0.3 mg per deciliter within 48 hours, a 1.5-fold increase within 7 days, urine output below 0.5 ml per kilogram per hour for 6 hours or longer. We won't go into detail here, but it's important to remember that AKI can be diagnosed even without decreased urine output. Next, let's review normal kidney physiology. Here is a simplified drawing of the kidney. Blood enters through the afferent arteriole, passing through glomerulus, and leaves through efferent arteriole. Filtrate then enters tubules, collecting duct, and finally flows into ureter and bladder. To produce urine properly, the kidney needs adequate renal blood flow, enough perfusion pressure, proper glomerular filtration, and the normal outflow of urine. A key physiological point is that afferent arteriole is dilated by prostaglandin, and efferent arteriole is constricted by angiotensin II. This balance helps the kidney maintain GFR. Now let's move on the mechanisms that cause AKI. 1. Pre-renal AKI. This occurs when the kidney simply doesn't receive enough blood flow. Common causes include hypovolemia, shock, status where total body fluid is high but effective arterial volume is low, such as chronic heart failure, reverse cirrhosis, hepatorenal syndrome, abdominal compartment syndrome, and nephrotic syndrome, and so on. And renal artery stenosis, especially bilateral. In a solitary kidney, even unilateral stenosis matters. And drug-induced perirenal AKI also occurs. NSAIDs block prostaglandin and prevent afferent dilation. Calcineurin inhibitors like sclerosporin and tacrolimus can also reduce renal perfusion. There's one more point residents often misunderstand. ACE inhibitor and ARBs are not harmful to kidney in general. They are kidney protective in chronic disease. However, when renal perfusion is already low, the kidneys rely on angiotensin II to constrict the efferent arteriole and maintain GFR. Blocking this response can reduce filtration and worsen AKI. Next, posterior AKI, obstruction of urine outflow. This is usually easy to imagine. Examples include benign prostatic hyperplasia, retinal stones, neurogenic bladder, or tumor-related obstruction. A very important clinical point is this: postrenal AKI requires bilateral obstruction or unilateral obstruction in the solitary kidney. Unilateral obstruction in a patient with two functional kidneys does not cause AKI. The last one is intrinsic renal AKI, injury with the kidney. Let's review this using the normal urinary pathway. After filtration, the fluid passes through the tubules, intestine, and glomeruli, and injury can occur in any of these areas. ATN is the most common form of renal AKI, according to about 80%. It is caused by tubular cells necrosis. Causes include ischemia, drug toxicity such as aminoglycoside, cisplatin, methotrexate, endogenous toxin such as hemoglobin caused by hemolysis, or myoglobin by rhabdomyolysis, uric acid, and benzoate proteins. Because the tubules are damaged, urine becomes dilute and poor concentrated, and typically muddy brown casts may appear. And next one is acute interstitial nephritis, AIN. This is inflammation of renal intestine. The most common cause is drug-induced hypersensitivity, seen with antibiotics, PPI, NSAID, and others. And it can also occur with fungal or viral infections, infiltrative disease, sarcoidosis, and amyloidosis. The classic triad is fever, rash, eosinophila. The last one is glomerular injury. This includes HUS, TTP, RPGN. That's it for the core concept of acute kidney injury. When you understand AKI from the standpoint of pathophysiology, you build solid knowledge that stays with you and truly helps in both exams and clinical practice. Stay calm and act fast.